this conference is being recorded. So this is a two-part initiative. In order to, the first part of the initiative is this webinar where we will be giving a presentation leading towards a in-person meeting that we will be having in Miami on March 1st. The context of this webinar will then help inform that meeting. So please, we want to hear from you. If you have any questions, comments that will help us, customize the in-person meeting. This webinar will be focused on all of Florida, not South Florida, and so we will be presenting based on the whole state. So today we're going to be talking about the National HIV/AIDS Strategies Update to 2020 and how that informs targeted testing. Review some of the surveillance data that's associated with new diagnosis in the U.S. as in Florida, and explore how to identify local HIV testing barriers to increase specific engagement. We want to examine how current strategies like social network strategy and HIV screening guide our HIV testing process. So welcome to all of you. This work that we're doing here as part of this initiative is a collaboration that we have had for the past few years with the Florida MSM Collaborative. So we want to thank everybody who's a part of the collaborative as well as the Florida Department of Health for all of their support and being such great partners for us. My name is Eric Valera, and I am the Program Director for Latinos in the Deep South at the Latino Commission on AIDS, and I'm joined today by my colleague Tony Ochoa, who's a Program Manager for National Latino AIDS Awareness Day, CIVA Specialist 3 at the Latino Commission on AIDS. So thank you all for joining us. Just a little bit about who we are. The Latino Commission on AIDS is a community-based organization in New York City that is founded in 1990 to fight HIV in communities nationwide. We work throughout the 50 states and territories. We have local, national, and regional programs, and we work in the areas of behavioral health research, HIV prevention and HIV promotion, capacity building assistance, testing, access to care, and health policies for community mobilization. Our capacity building assistance division works in three components specifically: high impact testing, prevention with positives, and organizational management. We conduct trainings and technical assistance to be able to help you strengthen your organizations in any way you need to. So we're going to be focusing on targeted testing and understanding what targeted testing means overall, and how to be able to use this practice of targeted testing to be able to meet your goals as a program, as well as to be able to make that impact in the community along the continuum of care. So to understand first what targeted testing is, we have to understand how targeted testing differs from its other strategy, routine HIV testing. So
great. Thanks, Eric. So I'm hearing that some people are saying they're having a hard time hearing us, so I tend to have a pretty booming voice. Hopefully you'll have a chance to hear us better when I speak up here. So again, thank you guys for joining us this afternoon. Like Eric just mentioned, I think it's critical for us to really lay the groundwork as far as what targeted testing really is and how it relates to other testing strategies and kind of their place in making sure that we make an impact in the epidemic. So we're trying to make this as an engaging webinar as possible. I understand sometimes webinars can be a little dry. So we've added a couple of polling questions to make it as engaging as possible. And again, continue to use that chat box if you have any comments or questions. So on the screen here, you see that we've showcased targeted versus routine testing. And the main takeaway here is that based on new recommendations by CDC is that everyone should get tested, anyone that's within the ages of 13 to 64. And in that case, we're really talking about routine testing. When we're talking about targeted testing, that's slightly different. In targeted testing, we're speaking about making sure that we're screening and testing particular populations that we've identified locally to be at high risk for exposure to HIV. So that's pretty much what we mean when we're talking about targeted testing. Is we're not testing everyone and anyone. We're pretty much targeting the right people using the right practices in the right places, like the HIV/AIDS strategy denotes. So again, targeted testing tends to focus on a particular population that's considered high risk versus routine testing, where we're really talking about volume testing as many people as possible. Which is why in situations oftentimes we're not faced with organizations that are funded to do targeted testing or asked to kind of test a set number of people, when in yesteryear that really wasn't the case, right? So a lot of you might be seeing that you're being asked to test 500 people, conduct 500 tests with a certain seropositivity rate. And what this means is that, if you conduct 500 tests, like the screen shows, 10 of those tests being positive, you'll find that 10 out of 50 would be positive. So 1 out of every 50 people you test would be positive, and that will yield a 2% positivity rate. So what we're being asked to do now is really be mindful of the people that we're testing, making sure the people that we're testing in targeted testing are really considered high risk, right? And which is why in certain situations we're not being offered strategies like screening, doing a risk screening with someone before you test them to find out whether they're really at high risk for exposure or not. So what are the challenges with this? Oftentimes we see that when we're doing targeted testing, we're hitting the same places oftentimes, so we're not yielding new people as far as positivity goes. So we need to be more mindful of how we're doing outreach to really engage those populations that we wouldn't engage through routine testing otherwise. So again, there's challenges with targeted testing, and it's intentional that we have challenges because these populations that are oftentimes most affected and high risk for HIV are the most difficult to reach, which makes us have to be a little more creative when it comes to how this is done, which is why we have this webinar and this process. So here I want to ask you guys before we move on, and this is the polling question I was talking about a minute ago. And the question is, the positivity rate is generally higher, and that should be routine testing, not routine. Positivity rate is generally higher in routine testing than targeted testing. Do you think this is true, false, or do you think the positivity rate is about the same? So again, positivity rate is generally higher in routine testing than targeted testing. Do you think this is true, false, or do you think it's about the same? Go ahead and answer what you think is the right answer. And then once we get a certain number, we'll display the answers on the screen. So we're seeing about the majority of people saying that it's false. We have about a couple people saying it's true, and then one person saying they're about the same. So again, as you can see, the majority of people are right. Like we mentioned a minute ago, routine testing is really about volume, right? It's about testing as many people as possible. In situations where we're doing routine testing, it's really about normalizing testing, reducing stigma, making sure that everyone knows their status, which is why we really don't focus much on positivity rate when it comes to routine testing, as much as we do in targeted testing, because targeted testing is really about testing a few people that are really considered high risk, which will yield a high positivity rate. So positivity rates is usually more important when we're talking about targeted HIV testing. Okay? So I want to ask another question then. Is one more important than the other, right? Is routine testing more important than targeted testing? So that's the other question I have for you. Is one more important than the other? So the options are routine testing is more important, targeted testing is more important, and the third option is they're both important. What do you think? Awesome. So we're seeing a good number of people saying about the same again. As you see, the majority of people saying they're both important. Again, they both play a very distinct and important role in us ending the impact of HIV/AIDS and the proportionate impact it has in certain populations. So again, they're both useful and necessary to the work that we do. And it's just a matter of number of us are tasked with doing one versus the other, and some of us might be doing both simultaneously, right? But they're both viable and important processes to the testing, right? So with that said, I want to, now that we've kind of set the groundwork for really having more advanced conversations around targeted testing, we're going to dive into looking at the national updated 2020 HIV/AIDS strategy through an HIV-targeted HIV testing lens, right? So as many of you might already know, there was an initial strategy that came out in 2010, and it was recently updated, and it's called the strategy updated for 2020 because these are goals we have set forth to meet by the year 2020. And of course, it would make sense that we would update the strategy, being that there's a plethora of things that have advanced in the field that we work in within the last 5 years. So some of the things are included, like, there's things like PrEP now and the Affordable Care Act and the way in which HIV/AIDS testing is recommended in different settings. All these different things that you see outlined on the screen, along with achievements and new barriers, really dictate the need for us to update the strategy to make it more effective to the current platform in place that we are as far as the field goes. So another question for you guys, okay? And this is pretty much the way, just to kind of get a feel of how the strategy is structured. I have a question here that says, how many steps are in the updated 2020 strategy? Are there 4 steps? Are there 10 steps? And are there 11 indicators? So what do you think? 4 steps, 10 steps, and 11 indicators. And this is really going to help us be able to look at it a little more critically when you see how it's structured. So this is about the structure of the strategy, really. So do you think are there 4 steps, 10 steps, or 11 indicators? Go ahead. And I'm seeing less people answer this question. If you don't know the answer, just take a wild guess. That's okay. So you'll see that oftentimes the reason why this can be a little confusing sometimes is because it's a very layered strategy. So you'll see that there's 4 goals, but these aren't the steps of the strategy, right? So sometimes you hear there's 4 goals in the national HIV/AIDS strategy. The first one being reducing new infections. Number 2 being increasing access to care and improving health outcomes for people living with HIV. Number 3 is reducing HIV-related health disparities and health inequalities. Number 4 being achieving a more coordinated national response to the HIV epidemic. And these all overlap in a lot of ways. So it's difficult to say that one particularly focuses on HIV testing or targeted HIV testing because really HIV testing is dispersed amongst all of them because they're very much intertwined. So there's 4 goals, and each goal has a set of sub-steps, right? So each goal has a certain number of steps, and within each one of those steps, there's these things called action items. So these are very action-driven steps once you get to the steps of each goal, right? And to have us measure the success of the strategy and targeted numbers, the strategy has also included these things called indicators, and these are the things that were created to help us measure how successful we are in meeting the goals outlined here. So when you first saw the goals, they seemed pretty fuzzy-wuzzy. They seemed, oh, this can mean anything, right? And they become more concrete as far as what they mean throughout the steps and eventually the actions and how they're measured, right? So an example of that is I'm showing now on the screen goal number 1, right? This is where you start seeing a layer of how detailed it will get throughout the strategy. When we're talking about reducing HIV infections, step 1 is intensifying HIV prevention efforts in communities with HIV is most heavily concentrated. And this includes a series of what you see now as the actions. And if you read through the strategy, you'll see each one of those is laid out in more detail. So each goal has a set number of steps and a set number of actions. And then the indicators I talked about. And throughout the strategy, there's a total of 10 indicators that are going to help us measure whether we're successful at meeting the goals outlined at the beginning of the strategy, right? So when we're talking about goal 1, which we see has the meat of HIV testing, where it kind of speaks of it directly, even though, again, it's kind of dispersed throughout the strategy, the way in which we're going to measure whether we're successful at goal 1 is through these 3 indicators. The first one being increase the percentage of people living with HIV who know their serostatus to at least 90%. That directly is HIV testing. It's an inclusion of both targeted and also routine testing, okay? And then we're also going to use indicator 2, which is reduce the number of new diagnoses by at least 20%. And there's a bit of a conundrum there, which I'll explain in a minute. And the third one being reduce the percentage of young gay and bisexual men who have engaged in high-risk behaviors by at least 10%. And again, we're being very explicit about the population that we're really trying to engage here at a national scale, because again, this whole idea of the right people in the right places with the right practices. So if you look at this a little more critically, when we're comparing the 2010 strategy to 2020, I've highlighted it here, but to make it a little easier to read, I've kind of increased it here. So the 2010 strategy said increase from 79% to 90% the percentage of people living with HIV who know their serostatus. And what we see now, it's really not much different. What we're seeing is increase the percentage of people living with HIV who know their serostatus to at least 90%. So what we pretty much did here is we just knocked out that 79. And luckily, since that strategy came out in 2010, there have been major improvements as far as the number of people that know their diagnosis, where it's currently, since we measured it last, projection of 86%. So we're about 4% shy from what it's been measured recently of meeting that goal set forth for 2020. So this is where I'm going to get a little more abstract, and it might get a little more difficult to kind of have some more didactic dialogue. But the strategy heavily relies on using new diagnosis as a metric of success. So what we need to do now, what I'm going to ask you guys to really think about, is what's the difference, if you might not know already, the difference between newly diagnosed and incidence data. So newly diagnosed data or diagnosis data versus incidence data. And the takeaway here is that they're not the same. HIV incidence refers to persons newly infected with HIV, whereas individuals newly diagnosed with HIV may have been infected years before being diagnosed, right? So oftentimes we'll come across populations where they won't find out that they're HIV infected until they're already at late stages of infection, usually stage 3 AIDS, right? In that situation, there's a very distinct difference between incidence data and diagnosis data. Diagnosis data speaks more about when a particular group of people were diagnosed, versus incidence data is more about infection, when did they become infected, right? So I have a question for you here, which is to help us decide who we should target for testing, which gives us more of a real-time picture of who is becoming recently infected. Newly infected incidence data or new diagnosis data? Newly diagnosed. So again, to help us decide who we should target for testing, which gives us more of a real-time picture of who is becoming infected recently. And the options are incidence or newly diagnosed. Which one do you think gives us more of a real-time picture of who is becoming infected? Incidence or newly diagnosed data? So we have about a third of people saying newly diagnosed, and we have about another good amount, so about a third saying newly diagnosed, another two-thirds saying incidence. So the truth of the matter is, if we're looking at who we should target, what gives us, and again, air quotes, real-time picture of who's becoming infected, incidence does, right? Because incidence, that's what incidence is. It's data that lets us know who's becoming infected most recently. So now I have a question for you, and this is where it becomes a little layered. Which does the updated 2020 National HIV Strategy use for its indicators? Do you think it's using incidence, newly infected, newly diagnosed, or both? What's the National HIV Strategy using for its indicators to measure its success? Is it incidence data, newly diagnosed, or both? So we're seeing a good number of people saying both. So that's kind of where we're at right now, about 50% saying both, about 25% saying newly diagnosed, and about another quarter saying incidence. The truth is that the National HIV Strategy is relying solely on diagnosis data. And there's a reason for this. When it comes to using diagnosis data, it's routinely published, it's standardized across the board in states, and it's available in all states. A lot of states and locations aren't being asked to produce incidence data because it requires another level of process that's oftentimes very difficult to do. There's tests and technology that exist that are making it easier for us to capture incidence, but it's not as readily available to certain areas as it is in others. So it's a lot more standard across the board from a national scope to use diagnosis data. Although in locations like Florida, where you guys all live, incidence data is being captured, which is very useful because it's giving you more of a real-time picture of who's really becoming infected and where to target your efforts when it comes to targeted testing. So if we're looking at diagnosis, let's say, and this kind of to hone in on this concept of diagnosis versus incidence data, let's say you see a decrease in diagnosis among a particular population. Because we're using incidence data, this could be a couple reasons, right? It could be because there's a decrease in the number of tests being done. It could be because the tests are being performed on populations that are at lower risk, so we're not really testing people that are high risk. Or it could actually be that it's an indicator that new HIV infections are decreasing. It could be one of these things, right? But because we're using diagnosis data, it would require us to take another step in really figuring out what's really going on. And again, Florida's in an advantage in the sense that you have incidence data, which Eric will present in a minute, which really helps you decide where you should focus your efforts as far as targeted testing goes. So that's kind of where the HIV strategy is. And again, the fact that the HIV/AIDS strategy, the updated one, is now using diagnosis data, that was a change that we saw from the initial strategy to the current one. And that it was an easier kind of manage, and there was a bunch of indicators that were changed. And it was a decision that was made to make sure that we focus more on diagnosis numbers because of the reasons outlined here. So with that said, I'm going to go ahead and pass it on to my colleague Eric, who is now going to talk about national and Florida-based HIV surveillance data.
Thank you, Tony. So now we're going to start kind of broadly and then work our way in as we take note of this practice of finding the right people, the right places, and the right practices. So let's start with the right people. Thinking about the right people in terms of who is impacted by HIV right now, who are those who we need to capture within the targeted testing process. So then we look to see what are the adult HIV infection cases in Florida as in the U.S., and we see they mirror each other, 20% female and 80% male. But that doesn't give us the whole picture either. So we see, and these slides are courtesy of the Florida Department of Health, the epidemiology, and we see that when we compare the mode of exposure in the U.S. as in Florida, we see that the majority of those who are diagnosed are MSM. 30% are heterosexual, and then the other categories of IDU and MSM combined with IDU behavior. So we know. So this gives us a bit more of the picture. However, it still doesn't tell us as much. So then we look at the race and ethnicity, and we see that the majority of those who are impacted are Black, followed by Hispanic and white. And this is the same for both male and female, although at different ratios. So if we have that the right people, we start to look very broadly at who are those who are being impacted. We see a lot of intersections between gender, mode of exposure, and race and ethnicity. But then,
Eric, can you speak up? I think some people are having a hard time hearing you.
I'm
So
sorry.
Maybe try yelling.
Is this a little better? Is this a little better? Is this better? Hello?
Try going and yelling if you can.
Hello, better. Okay, good. All right. So now we're going to look at what the right places are and where are these places. So let's start broadly. Let's look at the U.S. as a whole, and we see that Florida is definitely one of the spots where the HIV epidemic has taken a toll. But Florida is just one state amongst 50s, and this also includes territories. So we have to look a little bit more in depth, and we look at the counties that are being impacted. And we see that in South Florida, we have Dade and Broward County, we see the Central Florida area and the Duval County region up in northern Florida. These are much more impacted areas, and looking even more in depth from there, this could be broken down even more by zip code and other types of mapping that could be done to help indicate what are these geographic areas where we are that we need to be targeting. So then the third part leads to the right practices.
The right practices really have to do with several things, right? So we look at epidata, and epidata really gives us, as what I like to start to describe as the once upon a timeline when it comes to telling a story. The once upon a timeline being that it really sets the groundwork and gives us a very objective perspective of what's going on, right? So there's a series of other things, though, that data oftentimes doesn't tell us. So from looking at data geographically or demographic, it really lets us know where the epidemic's concentrated. It lets us know it's impacting the most. But there's a series of other things we need to be mindful of when we're doing testing to really help us make sure that it's effective. And this is something that in marketing we call population segmentation. And population segmentation is one of the first series and steps that we usually do when we do targeting, when we're targeting in a commercial sense, selling a product or selling, something like Red Bull. So first we want to make sure that we know who we're targeting. We want to segment different populations, figure out who we want to target based on all the populations we segmented, and then position. And oftentimes you think of positioning in the sense of HIV testing, not only the test itself or how we're doing the test, but also us as organizations. How do we change our organizations to really fit the needs of the populations we're targeting? So it's a bit of a requiring of doing some formative assessment externally to see what's kind of going on in the communities we're targeting, to really help us understand, well, why are the populations that are being affected or the populations that we're being asked to test, why aren't they getting tested? Is it really because of transportation? Is it because of lack of knowledge? Is it because a plethora of other things that we really need to engage in formative assessment to figure out, right? So there's a series of things that we can consider when we're segmenting a population to be more specific. So usually our funders will say things like, you're tasked to target YMSM of color, right? And those are very closely tied to demographics, but that doesn't tell us anything about the values of the population we're targeting, the reasons they're not testing, the social determinants are kind of existing in that hinder them from wanting to get tested. And that's where some of the legwork needs to come in on our part and making sure that we figure out why are the populations that we're tasked to work with really not getting tested. Because that's very different, contingent on the environment that they're in. So even if you look at North Florida versus South Florida, the populations that exist there, the reasons for them getting tested might be completely different, which will require different programming, different recruitment methods for testing, and also a different structuring of our programs when it comes to testing to fit the needs of the populations we're working with. So again, the way in which we can generally define a population further are demographic characteristics, things like social structure, education, occupation, ethnicity, things like this, health beliefs, attitudes, knowledge, beliefs, and values, enabling sources, so things like location, where they're located, maybe that's a barrier to them getting tested. Testing technologies being used, maybe there's other technologies that they might find more useful as far as testing goes. Counselors or testers themselves, and peer norms. So again, all these things really dictate whether someone's going to get tested or not, and a bunch of other things also dictate whether someone's going to get tested or not. And we need to figure those things out through some level of formative assessment once we've defined that population to really figure out how do we engage them. So now I have a question, another one of my poll questions, and this one you can select as many as you want, okay? So the question is, have you or your agency ever engaged in any of the following formative assessment steps? So check all of the ones that you have done or your organization has engaged in. So the options are looked at existing data, and we all should have done that because we kind of did it quickly just now. Define target population, survey of internal external staff, community observation, community mapping, spot interviews, gatekeeper key informant interviews, and focus groups. So again, the benefit to engaging in this formative assessment process is it really helps us understand better, beyond just saying YMSM, why the populations we're being tasked to work with aren't getting tested, right? What are the barriers that are preventing that population we're testing to getting tested? Or why are they being impacted the way they are when it comes to incidents, right? So this is what we see. We see the majority of people have looked at epi data, which is good because we all just did a minute ago. We've defined a target population. A good number have said they've done community observation, community mapping. And again, it isn't that you ever have to do all of these, but engaging in some level of formative assessment is key to customizing our programming and really filling the needs of the populations we're targeting. It's going to ensure that the programming that we're engaging in when it comes to testing is fruitful. So what I want to do now is, again, reaffirm the fact that formative assessment is key. And if you haven't done so, programs like ours, like Capacity Building at the Commission, exist to support organizations like yours in doing processes like these. So again, please make sure to use this as a resource to help you do things like this, because that's what we're here for. I'm going to kind of go into this idea of really defining a population further than just things like YMSM or YMSM of color. Is that oftentimes we stick to what the funder says our target population is and don't dig a little deeper to really define it further and really help us hone in on who we're targeting, which will make sure that our programs and recruitment are effective. So again, we can segment by age, by country of origin if we're talking about immigrants. We can segment by race. We can segment by multiple sex partners, so sex practices, right, behavior. We can by demographic, things like sex with men, with women, with both, with transgender, use of condoms, so again, something that's closely tied to behavior. And then things like HIV is only for gays. So again, this is more of a beliefs thing, right? So we can segment by a plethora of things that we see here, beyond just saying things like YMSM of color. And an example of this is if we're talking about, let's say, YMSM of color, we have here two populations that fall under that category of YMSM of color, but are completely different populations, and that you would have completely different programs and completely different recruitment strategies for these two populations. So we see that the first one being African American men, ages 25 to 35, self-identified gay, do not know their HIV status, engage in protected sex with multiple male partners, lives in blank, it could be anywhere, and uses condoms all the time, right? Versus South American men, age 35 to 45, with no relatives in the country, not self-identified gay men, do know their latest HIV status, and engage in unprotected sex with a single partner, male, and monogamous. So again, even though they fall under the same umbrella of MSM of color, those programs that you would probably use to target these populations, to the segmented populations here, are completely different. But you can totally see how segmenting it and defining it here the way it's done here is really going to help you structure your HIV tested program and really guide how you do engagement and recruitment with the populations that are listed here beyond just saying MSM of color, right? And that's the key takeaway that I want to have here is that, again, segment a little further. Assess the values through formative assessment. Assess the beliefs and barriers to the populations that you're working with to really help you better target the populations that you're working with, because this process here is key. I saw someone just ask what spot interviews are, and I'm guessing that went back to the question of formative assessment. Spot interviews are a very quick, if you ever come across a process where someone stops you on the street and says, hey, do you have a minute for 2 or 3 questions? That's a spot interview. It's nothing lengthy. You're pretty much getting a pulse or temperature of people's beliefs in the community. And things, if you're looking, let's say you were trying to find out where a certain population is to do targeted testing there, the questions you would have during spot interviews would be like, hey, do you know where gay men that are black hang out, right? Do you know where what gay black men do in this neighborhood, right? Those are the type of quick, fast questions you would ask somebody during spot interviews on the street to try to figure out a particular objective or goal you have in mind. So thanks for that question. So again, doing segmentation is key, right? So what I want to introduce now is, again, going in more depth as something as far as the structure goes, to really help us understand what we mean when we're assessing beyond just the populations we're working with, really understanding the environments that the populations that we work with are in. So we have things like the Lewin formula or equation. And Lewin was a social psychologist who came up with this idea of, rather than focusing solely on the behavior that we're trying to change, or solely focusing on the person, let's put a majority of the weight and effort in really understanding the environment that that population or person lives in that causes them to act the way they do, right? So in here, and it's not really an equation, but it's kind of put this way, where B equals a function of P times E. And what this really means is the behavior we're trying to address, in this case being testing or not testing, is a function of the individual in their environment. So to help us understand this better, you see it's laid out here that the behavior we're trying to talk about, the behavior is not testing, is a function, has to do with the fact that there's a population based on characteristics, things like demographics, in that person's environment. So we know, a lot of us know that oftentimes the populations that we work with that are high risk are unemployed or are homeless or are highly stigmatized or lack social support. All these things really dictate whether someone gets tested or not. And it really does vary from location, from population, from subgroups, more and more. So it's important for us to really identify these things, whether they're structural or social, that really determine whether someone gets tested or not. And these things you're going to find out through formative assessment. So you could imagine if you've done some formative assessment, you find out that, oh my God, the majority of people that we work with aren't getting tested because they don't know where to get tested. The majority of recruitment strategy is going to be focused on letting people know that you exist to do testing so that they are informed of somewhere that where they can get tested for HIV. Right? So again, these tie in closely to the strategies we're talking about. And these are all good practices, right? These are all about good practices that we should be engaged in when it comes to targeted testing. And there's strategies that exist to help us do this, and some of you guys might already be doing this. And it's a matter of us really fine-tuning these processes or engaging in them as a first step altogether if you're not using them already. So a lot of you might be using recruitment strategies like SNS, which we'll talk about in a minute, things like partner services, like outreach and inreach, community group level interventions, peer education, peer programs. All these things help us target the populations we're working with, right? And there's some that really go a step further and really put into this category of what we call client engagement. And client engagement is key because we're now engaging the populations we're working with in the process of actually using targeted testing. So an example of this is SNS itself. It's a mechanism that really does a great job in exemplifying client engagement. And in social network strategy, it's not what we oftentimes think of. Usually people think of social networks, they think of Facebook. But social network strategy is really about the way in which people connect. And there's a strategy that exists that organizations use in which they're connecting with high-risk participants and asking them to bring in their friends and acquaintances to receive services or testing. So you can imagine, even in your real-life situation, if you had a friend say, hey, Tony, I just went to this place down the street called Burger and Lobster. The food there was amazing. You would be more likely to go to Burger and Lobster if your friend told you that if some stranger that you're not very connected to did, or if you saw a flyer out somewhere in the public, right? So the fact that you know someone that's part of the target population is engaging their friends that they already know to testing is a lot more effective than having an outsider, and I'm putting outsider in air quotes, come in and do it for them. And it kind of produces a snowball effect where you're asking high-risk participants to bring a number of people to participate in testing, and then asking those participants that they brought in to also bring other friends to come get tested. So this is considered a very useful tool when it comes to engaging high-risk populations, and that this when it was during this demonstration project, it yielded a 6% positivity rate versus what we see nationally is generally about 2 or 3%. So it yielded a very high positivity rate. And on top of that, the people that were being engaged for testing were in the category of high risk, right? And again, what we're going to talk about in a minute is that risk is relative. Risk is not constant. And that'll be understood better in a minute what I mean by that. And what I have here is pretty much a diagram of what SNS looks like. So if you could see the big shapes in the middle, those are what we call recruiters. And those recruiters bring in their friends to get tested, which are the small little circles. And then you see that the recruiters, their friends can also become recruiters, and then they recruit their friends to testing. And everyone that's filled into a color, a red dot, is someone that was diagnosed HIV positive, right? So this is, again, a strategy that's currently being used, and some organizations might already be using it locally. So if you haven't heard about it, we welcome you to ask us more about it later, and we're happy to work through that process with you in more detail. And this process here, you might have come across also, and it's this idea of risk screening, and having dialogues with partners locally in several locations. Oftentimes you get a lot of pushback when it comes to this idea of risk screening, and that's because what you're doing here, it's a process that's very similar to what you would see in a risk assessment, but you're doing it before you're actually conducting the test. So what you're doing is within your own organization, you're predefining who is at risk and saying we won't test anybody unless they fit a certain set of risk behaviors that we're looking for, or are part of a set population that we're looking to test, right? So think about a risk screening tool as a risk assessment, but instead you're doing it before you actually conduct the test. So in this case, I have an example of you screen someone, right? So let's say you do this test, this screening before you even test them, and then you find that this person's a South American man who's between the ages of 31 and 40, not self-identified gay man, does not know their latest HIV status, has engaged in unprotected sex with a single male partner, and is in a monogamous relationship. And the question, ask yourself this question here, is if you knew this information about this person and you hadn't tested them yet, would you do the test on them? Yes, why or why not? And you don't have to answer back, but think about that, because that answer is very different depending on where you're located, because there's different risks involved in different locations, meaning that someone might not consider this person high risk if they were in somewhere like Puerto Rico, right? Or maybe someone would test them depending on their funding stream. So again, the process, what I'm trying to explain here, is that you're screening someone before you even offer the test to figure out whether they're at high risk for HIV or not. And if it shows up that, hey, you don't consider them high risk, then you end up referring them to other services, or referring them and giving them knowledge as far as, hey, based on what you're telling me, you're not at risk for HIV, but I can refer you to a clinic or a place where they do routine testing so that you can get tested. So again, the reason why a lot of organizations and agencies are doing this is to really make sure that the people that they're testing are high risk before they even give them the test. So again, different ways in which organizations are using methods like screening tools and SNS to really engage populations that are defined as high risk. And what I want to hone in again here in this process is this idea that risk is not constant. Risk changes. Even in your own life, and even some of the populations you might work with, you might encounter that certain populations, their level of risk is seasonal, meaning that they engage in more risky behavior during the summertime than they do during the wintertime, right? So this idea that risk isn't constant is something that we should be aware of, and it's something we should put into practice when it comes to us doing targeted testing. And really understanding, why is risk seasonal? Why is risk not constant? And how can we define risk beyond just like a demographic thing, because sometimes we'll define risk as MSM, but in reality, I could be considered a man who has engaged in sex with men, but if I haven't had sex with someone in over 2 years, and I'm a man who considers themselves gay, would I be at risk for HIV, right? So again, ask yourself these questions. How does your organization define risk? beyond just a demographic parameter, but really about a behavior, and how is that included in how you engage certain populations or screen certain populations for HIV testing. And those are all things that we should consider as good practice when it comes to testing. And I know we threw a lot at you, but I think it told a good story as far as understanding targeted testing compared to routine testing, and then how that ties into the National HIV/AIDS strategy and how they're both equally important, and how we can look at local data to start telling us a story that once upon a timeline by looking at surveillance data and fill in those gaps to help us understand what the beliefs and barriers are for those populations through formative assessment to help us better segment and define that population so that we can then use things like social network strategy, then use things like a risk screening tool to really help us define who we're looking for and decide whether we would test this person in front of us or not. And again, all of this was developed intentionally to be very, very, very broad, but also a lot, because we want to make sure that we engage you. If you can, join us in the face-to-face training meeting that will take place in the Miami-Dade Health Department on March 1st, where we're really going to delve into this process in a lot more detail and get our hands dirty as far as what does this really look like when we're implementing it, and how could we work together and really develop strategies that make this effective for the populations we're trying to reach. So again, we exist to support you and the work that you do. What I'll do after this webinar is we'll send out the slides along with the recording, so you are more than welcome to share it with your colleagues. And also I ask you to ask your friends and colleagues to also join us during the face-to-face meeting. Right now we're about 20 people registered, so we have a few more spots left in case anyone wants to join us during the face-to-face. And we look forward to engaging with you. What I'm going to do very quickly is I'm going to unmute the lines in case anyone has any questions that we can address before we close out. So I'm going to unmute all the lines, so in case you're talking about something inappropriate, hold that thought.
The conference has been unmuted.
So again, the lines are currently unmuted. If anyone has any comments or questions, you're more than welcome to bring them up right now. Or even general feedback.
Hi, it's been a great presentation. This is Emmy from Miami. But I was, that last risk assessment that you were talking about, that some agencies will send them away to someone else because they don't think they're at risk, to me is a little bit crazy. For the simple fact that that person might have just gotten the courage to come at that moment and won't go anywhere else. Secondly, you have if we keep it to just that little assessment, which I know, it depends on the counselor. You have, how can you need to ask them why they came in the first place?
Right, and again, the whole point of bringing it up, and again, it's different from a risk assessment. It looks similar to risk assessment, but it's called the risk screening. And again, the main difference is that you're doing it before you actually conduct the test. And the whole point of us showing that is to kind of show the fact that internally within your organization, who you define as being at risk is set. An organization needs to come together and decide, okay, who are we defining as high risk? Who are we segmenting and who are we targeting in our efforts? So that everyone at your organization is on the same page. So protocol needs to be kind of met so that you can be able to do something like that. Great point. Thank you for that.
Yeah. I mean, the sad thing is that I've seen different agencies, and I've been around when they're conducting, screenings, and they'll have them sit in front of a tablet or something and fill out their information, and then test them, and then send them, So, and the screening is so short that they really get no risk, no true risk.
So I have a question for you then. Would that be a matter of adapting the screening tool, or is it a matter about internal protocols?
I think it's both.
So definitely. So I think it would be a matter of the organization themselves taking a step further and really adapting the screening tools and templates that are created to fit the populations they're working with, and also assess themselves internally, how are we defining risk? Very good point. Very good point.
Well, you'll hear me more on the first, so.
Great. And again, please don't hesitate to contact us for more dialogue on that topic. And again, that's what we're here for, is to really work with organizations on how to implement these tools better, how to do these processes, and make sure that things are kind of worked out the way we did. And I understand it's a very didactic process on webinars, but Thank you for being as engaged as you are. Any other questions or comments? If not, that's completely fine. Again, we're open for dialogue, one-on-one. Thereafter, feel free to send us an email. I'll be sending an email after this webinar. And again, if you can join us during the face-to-face training where we're going to really do some of these live, we would love to have you join us. And again, don't forget to fill out that post-webinar evaluation form. And thank you guys for joining us. Take care.
Thank you so much.